Fatima Rodriguez, Mike Gibson, and we're talking about how do we kind of stage the assessment of atherosclerosis. So, Fatima, we grew up in a world with the plumbing model, right? The stenosis was king. You just looked at a focal stenosis. You made all your treatment decisions based upon anatomy or some physiology. Where are we now in 2025? Things have changed.
Thank you, Mike. I always tell my house staff and fellows when we're on service that it's not just about stenosis, especially if we get a coronary CT for a clinical indication. They'll say it's clear, meaning there's no significant stenosis. And I'm like, actually, there's so much more information in those CT reports and really analyzing the plaque. What kind of plaque? Is it soft plaque? Is it calcified plaque? And really, these are tools, I would say, primarily to motivate patient decisions around intensifying therapy, but also for us to know, are we doing a good enough job with preventive therapies like lipid lowering therapy, antithrombotics, and anti-inflammatory agents?
So where do we start? Let's start at the beginning. So I come to you, you know, I'm a male, no real risk factors. What do you do in terms of screening? How do you decide, where to begin?
So great question. So I think the important distinction is it for somebody that's asymptomatic or symptomatic? And now identifying atherosclerosis is a really important part of risk assessment in my practice as a preventive cardiologist. Often the first test that is done beyond just the standard biomarkers, the lipid panels, is something called a calcium scan, which can identify the amount of calcified plaque. But however, we know that not all plaque that is vulnerable is calcified. In fact, calcified plaque is more stable plaque. So for some of these individuals, they may end up getting a CCTA that can show us not just the calcified plaque, but also soft plaque, vulnerable plaque, and can
So how
help
do you
us.
decide
Yeah,
though, how do you decide to go from a calcium score to the CT? So if you had a calcium score, this is always interesting to me. If you have a calcium score of 0, does that mean you have no risk? I mean, you could have a lot of fatty plaque and have a calcium score of 0 and still have events, right?
that's right. And in fact, I worry sometimes that patients with a calcium score of 0 may be inappropriately de-risked. They may feel like they don't need to do anything, right? Because sometimes calcified plaque can be a late stage of the beginnings of the atherosclerotic process. That said, I do not routinely order CCTAs in primary prevention just for the purposes of screening. And that's because those are currently not covered by insurance companies, and that's a very hefty out-of-pocket cost. However, there's another reason. For example, the patient may have subtle symptoms of chest pain, shortness of breath, or there's an anatomic concern that I have, then I do obtain the CCTAs. And we know these are being used a lot more clinically in the emergency department, for example, when someone shows up for evaluation of chest pain. And many of those patients are inappropriately de-risked because they don't have stenosis, as you mentioned. But there's a lot of information in there that may suggest that we have to intensify their therapy.
So the ER is still in the old plumbing model. They're not looking at disease burden. So, all right. Well, how do you then decide to go from just getting a CTA to getting maybe some more sophisticated measurements like the flow reserve or the plaque quantitation?
This has changed significantly over the past several years that I've been practicing as a preventive cardiologist. Now we're able to get CT FFR data to see if this is a hemodynamically significant stenosis for those intermediate lesions. Something that before we would have to go to the cath lab, right? So this can save us a trip to the cath lab and make sure those trips are much higher yield in terms of needing interventions. But in addition, they can quantify plaque, and different companies have different algorithms to do this to show us the total plaque, the vulnerable plaque. And importantly, if we're going to repeat a CT scan, it can tell us how our patient's responding to treatment.
So, all right, you identify some plaque, maybe mild stenosis. You put the person on some lipid lowering. What are you doing then in terms of imaging after that? Are you following? You mentioned that, repeat CT scan. Well, first of all, that first CT scan to get someone treated can be pretty motivating to show them the pictures. Is that true?
That's exactly right. So that's one of the primary reasons I order imaging for our patients is to really motivate behavior change. So with nothing as quite as motivating as seeing plaque, and especially some of my patients here in the Bay Area who are very data driven, they want to see are things getting better after I've really been doing everything that I recommend. And what happens is that sometimes they actually get repeated calcium scores, which is the exact wrong test to get.
Mm.
I actually had a patient in clinic the other day where her calcium score was going up. and her therapy was getting more intense in terms of lipid lowering therapy, which is actually a good thing, but that required a more nuanced discussion and a CCTA to show the plaque quantification. And in fact, her CCTA showed that we still had more work to do because there was quite a bit of soft plaque.
Yeah, I mean, statins can lead to calcification. There's some interesting studies of the GLP-1s with weight loss. You convert your plaque to calcified plaque. So,
What can't the GLP-1s do? It seems like this is really the treatment for all.
it's the longevity medicine of the future. So that's great. So you do use it to track the amount of soft plaque. Are you looking focally at soft plaque or are you looking at total plaque burden?
I think it depends on the clinical scenario. For most of us, especially the people that you want in the future, once we test the hypothesis that this really improves outcomes, we're going to want this to be a little bit more upstream of the specialty cardiologists. This is in the primary care setting, maybe general cardiology. So I think we should keep it simple in the sense that it's really total plaque volume we have shown can predict risk. I love plaque, and I know you do as well, Mike. We can kind of nerd out on plaque characteristics and plaque features. But what I think our clinicians really need is something that's actionable. Okay, we have this degree of plaque, this kind of vulnerable plaque, soft plaque, low attenuation plaque. Beyond some individuals may need an intervention, what else should we be doing when we have such an increased armamentarium of preventive therapies? Most of that is lipid lowering, but as you mentioned, there may be some role for GLP-1 medications, for anti-inflammatories that are currently in development, and of course, antithrombotics.
So have you ever seen any true regression on some of the scans you're doing, or do you just see stabilization? I mean, I don't want to get people's hopes up that we're going to dissolve all this. I mean, my first gig as a researcher was many, many decades ago in the Harvard Atherosclerosis Reversibility Project. I got to say, in the 80s, I didn't see a lot of regression. Of course, we had placebo-statin back then. So, are we seeing some regression now these days?
And I'll say this is largely in the research setting. There's not many patients that I repeat scans on unless they need it clinically. So in those patients, I certainly seek plaque analyses, look at the difference. But in a research setting, we've seen that this can really be a surrogate instead of a clinical trial. It takes a lot longer time to show that there's either regression, stabilization with treatment, and in fact can give us some mechanistic answers. So why do these drugs work so well to reduce cardiovascular events? And we've certainly seen that with the PCSK9 inhibitors.
So you and I are both at AHA. We both saw the Vesalius results. Is 45 the new 55? Should we be driving that number down to a lower level? And our folks are like me. There's millions and millions of people out there like me. Never had an event, got an elevated LDL. So what's our target now?
One of my favorite studies of the American Heart Association meeting, because it really shows us that even atherosclerosis without an event, which used to be our entry criteria for a lot of clinical trials, is still dangerous, and we can still reduce events by lowering LDL significantly. The European guidelines are telling us to seek lower targets, and I think that's where we're heading. We also know that it's very safe to have a low LDL. So I often say, how low can you go? And really, there's no danger to being as low as reasonable.
Yeah, my LDL is 19. So I'm very
I'm
happy.
jealous. I'm very
I'm,
jealous.
I'm very proud of my LDL of 19. Now, people say, isn't that too low? Well, no, there is no data suggesting that it's too low. And in fact, when you look at people who have PCSK9 inhibition like genetic traits, they don't have any cognitive problems or any other problems. So it's perfectly compatible with a long, healthy life. So are we going to get to the point where we just say lower is better, just get it as low as you can as long as you're tolerating all of it? Are there any downsides? I mean, for instance, statins can, in some cases, lead to diabetes. So are there any downsides to getting as low as you can go?
I think there is a downside to saying set it and forget it, which we've seen it with prior guidelines, that we do such a bad job at a population level as checking, and I just gave a lecture earlier today and I said it's really LDL pack years. So not having a target worries me because then I think people are just gonna not reach any target and really overall
You
we're not
said
gonna
LDL pack years. I think it should be LDL plaque years, but go ahead.
I like that. That's right. I'm gonna steal that.
Yeah.
LDL plaque years. It's just like smoking. And if we don't check it, if we don't repeat the assessment, then we're not going to know, is this therapy working? We know there's issues with adherence. But I do think as a population, the LDL, we're seeing this, right, Mike, in clinical trials, like LDL baseline, even when we're trying other therapies, are lower and lower. And that's really the direction that we're going. There doesn't seem to be a downside to having too low of an LDL, but it has to be sustained. And that's the hard part.
Thank you for joining us today, Fatima. And really, prevention is where it's going to be at, I think, moving forward. So, why wait on an event to happen? We really need to move from secondary prevention to primary prevention to primordial prevention. I'm sure you agree.
Couldn't agree more.
More is better, but longer may be better too,
And
right?
earlier is better, but it's never too late. So for those
Mhm.
listening, it's never too late to start lowering your LDL.
Thanks for joining us, and thanks to all of you for joining us here.